Hello, and welcome to today's webinar, Reinventing Credentialing and Monitoring Compliance with Shared Models and Agentic AI. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on your PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Kimberly Ide, Vice President, Healthcare Payer Solutions, Doug Gilbert, Chief Information Officer and Chief Digital Officer, both with Sutherland, along with Ankur Verma, Vice President at Everest Group. At this time, I'll turn the floor over to our speakers.
Thank you. Well, good afternoon, everyone. Happy to be here. Good morning to those of you who are on the West Coast. We're going to thank you for joining us for our Reinventing Credentialing and Monitoring Compliance. We're going to share a number of pieces related to how the modernization of credentialing is happening today. We'll walk through a little bit of the past before we get to the future, but we're excited to share all of it with you today. We're going to start with our introductions and give us just a second, and we'll give you a little bit more than you were given before. I will walk you through some credentialing history, the evolution of this, the challenges that exist today, and Ankur from Everest is going to speak from an Everest perspective in terms of what they're seeing as well. A little bit more detail on the state of the market today and talking about some of the things that Everest sees when they work with their clients. We'll ultimately move to shared credentialing and talk a little bit about what that is. Many of you may have heard about it. Many in the organization in the healthcare environment today haven't heard about shared credentialing, but in a shared model, we'll talk about that in a little bit more detail. And then we'll move to Doug, who will share with you about how Agentic AI and AI dynamics are impacting the healthcare world in general, as well as other parts of the industry. And then speak a little bit about the credentialing impact of that, or potential credentialing impact. We'll end up with market perspectives. So with that, I'm Kimberly Ide. I will be your MC for today, but we are a team and we're speaking about very different topics. I've been in the healthcare space for about the last 18 years, all in the provider data and credentialing space. I've been with Sutherland for the last couple of years, and I'm excited to share with you the knowledge that I know from my experience here. Doug?
Yeah, hello everybody. My name is Doug Gilbert. I'm the CIO and Chief Digital Officer, as announced earlier. So I look over everything and anything technology and digital, both inside of Sutherland and externally with our clients. My main primary focus anymore is obviously on AI. And within that, I serve on a lot of different councils. Just some of them would be, I sit on the AI council at Google. I am part of Stanford's AI Labs, which is called SAIL. I sit on Wall Street Journal Tech Innovation Council and others, but really excited to kind of walk through some of these thoughts.
Thank you. And Ankur?
Thank you, Kimberly. Good afternoon. Good morning, everyone. My name is Ankur Verma. I'm a Vice President at Everest Group, where I lead the healthcare operations team. Been with Everest for almost a decade and total experience of around 15 years working with payers, providers, and outsourcing service providers on transformation initiatives. Really excited to be on this discussion and looking forward to sharing some good insights with you.
Thank you. So we're going to start with a little bit of credentialing history and the evolution of where credentialing has come from, as well as some of the challenges that exist today. When we think about credentialing, it's really been evolving for 5 or 6 decades at this point. Starting in the 1960s with paper-based systems, really trying to verify the credentials of providers in hospital systems primarily at the time. And it was really driven around patient safety, malpractice, and hospital liability. At the time, very manual processes. We saw the expansion of managed care, and that drove some additional pieces. The evolution of credentialing has really been impacted by three factors. One is the drivers coming from whether it's the health systems or the health payers, the needs coming from those organizations to meet the compliance requirements and to meet the needs of their members. It's been driven by regulatory and compliance change. So you think about the evolution of regulatory from Joint Commission coming out in kind of the pre-80s world to NCQA, URAC coming in the 1990s, to the standardization of CMS in the early 2000s, and the evolution of that entire continuum. And it continues to happen as we talk about the NCQA requirements that are coming forward for 2025. Both Ankur and I'll speak a little bit more about those. And then technology. Obviously, back when we started with the credentialing capabilities, there was virtually nothing. And now we're evolving into much more integrated APIs and Agentic AI being applied in various ways around credentialing. Obviously, automation and other technologies through the middle of that. But the evolution of these systems has come a long way since we began. However, I will say that I still talk to clients today who still have very paper-based or manual systems. There's still a lot of manual work that flows through this whole credentialing cycle. Not everything is automated, upstream and downstream solutions, sometimes not integrated, and a lot of replicative work. The changing dynamics, I'm going to hit just on a few of these. I talked briefly about the NCQA 2025 requirements. When I talk to clients, and Ankur's going to talk a little bit more about this as well, this is one of the drivers that is really impacting them. How do we move toward this more continuous model for credentialing that is being driven by some of those new requirements under those NCQA 2025? The ongoing re-verification of credentials that were an every 3-year cycle, now much more continuous in that re-verification and the monitoring process. The rising telehealth and the multi-site practice models, again, driving a need for broader credentialing, knowing who's out there and where they're practicing, re-verification of licenses in multiple states, driving some pretty significant increases. The aging, retiring clinicians and specialties wanting to actually get people to replace them for adequacy and access reasons. Getting new providers into the system is driving a pressure on the turnaround times and wanting to move forward. I'm going to skip over to technology. AI and Agentic AI is enabling new capabilities that just weren't there before. And we'll talk a little bit about where those possibilities might be in Doug's section. And then finally, that pressure on turnaround time, the pressure on KPIs, the desire to have a more rigorous process around credentialing and driving towards the objectives that internally, both from a provider satisfaction perspective as well as from a financial perspective, are driving the business. And finally, I will talk a little bit about the challenges. Briefly, many legacy systems are still in place today. They're fragmented. The upstream and downstream processes are not as integrated as they could be in many ways. There's a lot of transition files that are passed back and forth. I still see a lot of emails with PDFs that are being submitted for applications. We see a lot of manual applications still in the world. Fax is still being used in many cases for the submission of information. That drives significant challenge in terms of getting that data into whatever data set it needs to be, but into the credentialing data set for the purposes of this. Though that interoperability, the manual processes are in fact driving, continued delay in credentialing and onboarding of providers. It's been in that 90 to 120 day onboarding cycle, I think, for as long as I've been in credentialing. And I'm seeing impacts. I'm seeing many organizations that through automation, through process improvement, are able to drive that down into the sub 30 day, even down into the 20-day turnaround time. I know I have clients that I've talked to that are trying to drive that onboarding process even faster to less than a week. So it's possible, but most organizations that I've run into still have some legacy components that are driving that operational impact to lead to that longer onboarding time. The impact of that is that increased risk of network gaps, etc. Those member appointment times and the accessibility from a member perspective. Providers are wondering where they stand in the cycle. Often there's lack of transparency from an operational perspective, so they don't know. They want to know, when can I start seeing patients? When can I start sending in claims? And from a plan perspective, we want them to do that. We want them to be able to see them as quickly as possible. So the challenges continue to persist from a legacy perspective, and the residual disconnects still are out there, leading to those operational impacts and the business impacts as well. So with that, I'm going to move into a quick poll. And I want, basically, this is about the audience and how the audience is seeing challenges meeting credentialing compliance. So for those of you who are actively out there, pretty much anyone, what do you see as that biggest challenge in meeting credentialing compliance requirements? Do you think it's the turnaround times and new provider credentialing, getting providers on board as quickly as possible? Is it B, meeting new regulatory demands, the NCQA 2025 requirements or others? The cost and budget to credential the network properly? Identifying how to optimize the process, sort of understanding where do I start? Or is it all of the above? So we're going to kick off a poll. If you would, please answer the poll with one of the answers above. And while we're waiting for poll results, Nikki, if you would kick that off. Ankur, since you and Everest spent a lot of time in the industry, maybe while we're waiting for poll results to come back, can you maybe talk about what you think the answer is going to be? What do you think the audience is going to respond to?
Absolutely, Kimberly. So I think this is an interesting question, and based on my conversations with some of the peer organization leaders, I believe all of them are equally important to them, right? So turnaround time, cost and budget, identifying how to optimize the process. But I think because of what has happened in the industry in the last 1 year, right, which is the NCQA 2025 reforms, I think because of that, a large number of peer stakeholders, peer leaders are thinking about the regulations and how to ensure that from a people, process, technology perspective, they are ready to to be compliant with the upcoming regulations. So I'll give an example. So, in the last 3 weeks, I have done 2 workshops entirely focused on the regulations. Regulations like, One Big Beautiful Bill, or regulations like the NCQA 2025 reforms. So from my perspective, based on my conversations with the healthcare peer clients, I think the regulatory demands would be something which might be top of the mind concern for the leaders as of now.
Thank you. So Nikki, are we finished with the poll at this point? All right. So what we have so far, just to kind of let the audience know what we're seeing, about 28% of you feel that it's turnaround times for new provider credentialing. That's the highest response. Second highest was identifying how to optimize the process at 11%. 6% indicated that it's meeting new regulatory demands. 6% said costs and budget to credential the network properly. And 50% of you said all of the above. So I think everybody is struggling with how do we do this. That 50% is pretty indicative. Does that surprise you, Ankur?
No, I think, as I said, all of these issues, challenges are definitely, top of the mind concern for healthcare payer clients. And I think if you think about it, all of them are interlinked, right? So improvement in turnaround time will also help in becoming more compliant. So I think it's not surprising as such.
Yeah, and that's, it's interesting because, credentialing is often not viewed as a strategic investment, but it's becoming more and more one. And I think, how do you convince an organization? That's one of the things that I hear is, how do I convince my organization why is this such a strategic investment that we need to make internally? So, All right. With that, Ankur, let's go ahead and head to you and have you talk a little bit about what you and Everest see as the state of the market.
Absolutely, absolutely, Kimberly. And I'll take from where you left, right, where you said that credentialing is not considered that strategic by healthcare payers compared to some of the other function, and that's true, right? So if you look into the last 10 or 20 years, uh, a lot of changes have happened in healthcare. Think about claims adjudication, right? Now using technology, we have the adjudication rates in the excess of 90%, right? On the clinical side, we have clinical decision support tools helping provider organizations in treating patients. On the payment integrity side, we have the secondary edit platforms which are helping healthcare payers in ensuring that the claims are paid correctly. But credentialing, not a lot has changed in the last uh, decade or so. And that's what when I speak with payers, and I speak with payers, almost hundreds of payers every year. When they have conversations with us, I think three or four key challenges come out, and I'll talk about some of them. Starting with manual workflows. So the reality is that even now, three out of four payers are using spreadsheets. They are using semi-manual tracker for credentialing for primary source verification, which is highly inefficient, right? You have to put a large number of people for do credentialing, recredentialing for verification, which is highly inefficient. And the manual workflows is one of the biggest issues that payer come to us with. Second, the fragmented systems, right? So if you think about the credentialing data that resides across multiple systems, so provider data management, enrollment, claim system, and as of now, for majority of the payer organization, there is no interoperability or integration that exists, right? So if somebody is checking onto that data, they have to recheck it multiple times. They have to make modification multiple times again, which is highly inefficient, and that's one of the biggest pain points and challenges for healthcare payer organizations. The provider dissatisfaction, right? So when we think about credentialing from a provider perspective, it's one of their biggest administrative efforts. You speak with provider organizations, and they always complain about rapidly changing rules, payers not providing them the required information, and so on, which also impact the onboarding time, and ultimately it impacts the member as well, because higher onboarding time ultimately results in the not enough providers being part of the network, and that's ultimately impacts the healthcare provider organizations as well. So payers realize this is an issue, they realize provider dissatisfaction is an issue, and they want to do something about that. And finally, the operational inefficiencies, right? When we think about the people, process, technology cost of credentialing for a payer, it's massive, right? We did an analysis some time back where we realized that on credentialing, payers typically spend 15 to 20% of their total provider management, cost or spend, which is a significant spend on a single process. So they really want to understand that how can they improve the inefficiencies, right? How can they get the right kind of talent? How can they get the right automation solution? How can they get the right third party partners who can help them be more efficient in the credentialing process? So Kimberly, Doug, when we talk about when we talk to payers about some of the issues, I think these things really come out. Uh, Now, as we move forward, I think what's important is that these are some of the perennial problems that exist in the industry, that have existed in the industry for a long time. But the NCQA 2025 reforms, right? I don't think it would be wrong to say that these reforms are, maybe the most disruptive events that have happened in the credentialing industry in the last decade or so. Uh, and let me touch upon some of them in detail and how it impacts the payer organization. So let's start with something like the verification timelines. Uh, NCQO has advised the reduction of verification timelines from 180 days to 120 days, right? Now that's a 30% compression of the timelines that payers have. Earlier, payers who used to do it in a more manual, more batch based verification, I think they have to change how they operate. They have to they have to have more real time workflows to address this compression in timelines. Similarly, something like addition of more demographic data. So now NCQA has advised payers to collect data on race, ethnicity, geography for health equity purposes. But that adds a significant administrative workload for payers, right? In a situation where majority of the payers, they are having manual credentialing operations, they have legacy systems. If they have to collect more data, uh, it's an administrative hassle for them. Uh, Something like inclusion of interim survey for early gap assessment. Now, it essentially means that now healthcare payers have to collect the data from provider organizations on a more frequent basis, right? So the verification, the recredentialing has to be more continuous. Earlier, it was they have to take care of it every 3 years, right? So I think the NCQA reforms have will change significantly how payers need to operate, and it will have impact both internally and how they are sourcing. I'll quickly touch upon some of the impact metrics as well. So clearly, there is a need for healthcare payers to think about automation as much as they can, right? So automation of primary source verification and more simpler, more rule-based function is something that they have to focus on. Uh, Similarly, integration and interoperability, right? So now we have technologies in the form of API through which they can integrate the credentialing platform with the other platforms that exist. So that's an area where they have to invest, and that's an area where they have to work with their partners. I'll also talk about the talent part of the equation because sometimes when you talk about technology, talents take a backseat. But what we definitely know based on our conversation with the payer organizations is that uh, the payer organizations have to continuously train the talent. They have to continuously help the talent adapt to the changing standards of credentialing. Uh, and finally, I think the issue resolution, the continuous feedback mechanism, the issue resolution, it has become much more important than it was earlier, and that's where payers have to focus on. Now, finally, I think I'll also want to talk about some of the innovations that we are seeing in the industry when we speak with some of the best-in-class payer organizations, right? So think about shared program models where multiple payers or multiple business units have a common credentialing partner or a common credentialing hub, which can help them save so much duplication of efforts and so on, right? And there are other best-in-class practices that exist in the industry, right? Something like automation-led scalable credentialing operations, right? Where you have a third-party partner who has helped you set up an automation organization for credentialing, and depending on the volumes, you can increase or decrease it as per the need. So I was saying that I think as healthcare payer organizations think about best-in-class models, the way they partner with some of the third-party organizations, we're also seeing outcome-based pricing arrangement. We're also seeing BPaaS kind of arrangements where the focus is on the outcomes that third-party organizations can deliver to them. So that's again a best practice that we are seeing in the industry. Uh, the change management and the interoperability part of the equation, right? So again, we have seen healthcare payers setting up change management organizations to help them towards more integrated functions for for credentialing, for provider data management, and so on. So again, that's another best practices that we are seeing in the industry where we believe payers can get value. With that, let's go to another poll. Uh, and the whole question is that when you think about your organization, so does your organization have prior experience with multi-payer or shared services model? If yes, please indicate the type of shared solutions your organization has implemented, right? And the options are no, we do not have any experience in shared models. Yes, we have experience in shared credentialing solutions. Yes, shared provider data management. Uh, yes, shared survey or assessment programs. Yes, shared provider outreach and or verification. Yes, multiple types of shared models or several of the above. And finally, yes, there are other shared models programs that you have within your organizations. So I would request all the listeners to vote for the shared programs that they have experience on. And as the listeners are, you know, polling, I would also want to ask a question to Kimberly. So, Kimberly, as people are filling up their responses, could you talk about history of shared programs and where we are today?
Sure. Yeah, thanks. Thank you, Ankur. And I'm looking forward to the polling questions. When I talk to organizations, unless you're participating in one, most people don't even know that they exist. And multi-payer or shared models, whether it's for credentialing or for other services, they've been around for some period of time. The first shared credentialing model that I know of was started in 2005, and it was in the state of Massachusetts for the plans in the Massachusetts market. It was a multi-payer credentialing model, still exists today. And then we started to see the evolution of state mandated programs for state Medicaid. In starting with Arizona, I believe, in 2012, and then in 2015 in Georgia, we saw it in Texas. They went live, I believe, in 2018. So there's some multi-payer credentialing models, mostly driven by state Medicaid mandates. There was a multi-payer that wasn't state mandated. The Massachusetts one is not state mandated, but there was another one that was started in the mid, I think, about 2012 as well, between two large payers that I don't believe is in existence any longer. So there are a number of those. There's also Symphony in California with provider data management. There is the California Pause. There's a group of plans that have come together to do the California survey there. So there's a number of different things that exist in a shared model. So let's see, the answers that I think we have is no experience is 67%, not surprising.
Yeah.
Shared credentialing, we don't have anybody. Shared provider data management, 8%. I'm guessing that's maybe in the Symphony. Shared provider outreach and verification at 8%, and multiple types of shared models about 8%. So, and yes, other is 8% as well. So if you answered other, we may reach out to you just to understand what that might be. But appreciate your answers. It's interesting. Again, a large percentage not in shared models today. So I'm going to talk a little bit about what a shared credentialing model looks like, how it operates, some of the sort of standard pieces that it needs to include, what is the real value associated with this, and then we'll talk about kind of how it works in a practical model. So the typical dynamics are you need a third party because these are, you're all multiple health plans that have your networks, and that's proprietary information. Where the provider practices, less proprietary, maybe where they practice in your network might be a little bit more proprietary, but fundamentally the information about the provider themselves is out there in published directories. So that is not proprietary information. What their license number is not proprietary to a plan. What their board certification is not proprietary to the plan. What their specialty might be from a credentialing perspective in the plan could be. So there's some things that kind of vary between organizations, but you do need that third party, and you need a common application. CAQH serves very well, but some of the organizations that have multi-payers have their own application model. There are other common applications outside of CAQH, but CAQH is fairly ubiquitous and does work very effectively for this kind of a model. Typically, there's a credentialing cycle. Everybody knows there's a 3-year re-credentialing cycle, and we're talking about re-credentialing because initial credentialing, you need to get that provider into your plan as quickly as possible, but then they need to fit into a re-credentialing cycle where that can be shared. That cycle, typically every 3 years. There's some states that are very limited number that are every 2 years, and that alignment across credentialing happens based on the model. In the state of Massachusetts, it's based on, I believe, its birth date. There are others that are on the earliest credentialing date. There's others on Social Security. So it kind of depends on how it's mandated and how it started and how much pain you want to take on the front end versus the back end. because there's trying to get into a cycle is always a bit of a challenge. But coming into an established model actually doesn't have as much pain, because that cycle has already been established, and then there's new information that basically you sort of jump on board with that cycle, if you will. So again, it's typically take the application once, credential once, and deliver out packets to each of the organizations. Most organizations that have most multi-payer credentialing models have a common packet, because it's driven by the state, for example, or it's driven by an organization that oversees that. They've established this is kind of the box that we're going to put around that. That doesn't always work for plans, because sometimes compliance departments need a broader, they've taken a broader interpretation of the NCQA rules. They need to have slightly different things verified during that cycle, and it may require opening it up. There are programs that actually give you configurable outputs. So it kind of depends on the multi-payer model. And then the sharing of costs typically happens, doesn't always happen. Some of the multi-payer solutions that I've seen that are out there, there's a price, a fairly reasonable price for each of the plans that participate. Some it's based on the level of overlap in the plan, in the overall program. Sometimes it is not shared. It's just you get the benefit of doing this. The value still remains. There's much lower provider abrasion. This is something that really does, if you think about how many organizations that a provider has to interact with, and Ankur underscored that for us in terms of that provider dissatisfaction and the level of work that they have to do to keep credentialed from provider office, to keep their providers credentialed and continuing to see patients and process claims. That provider abrasion is definitely minimized in this. And this typically drives improvements in both quality and in the provider completion because of the multiple shared model, and it often drives credentialing at that lower cost. It just depends on the program that's put in place. Concept is pretty simple. Multiple plans come in. Some plans will overlap extensively with other plans, some less with other plans. You can get to a standard recredentialing model where nobody overlaps. There's a 2x overlap, there could be a 3x overlap, there could be a 4x or 5x overlap, depending on the particular provider and how shared they are across participating organizations. I think the key to this is that the PSV packets are distributed independently in most cases. The decision, the committee decision is made independently. State of Georgia is a little different. They make it one time and they pass that along. But in most cases, the plans continue to have control over who comes into their network, who stays in their network, who continues to be able to see and serve their patients, or their members, and that ongoing monitoring and re-verification of expiring elements can happen on a common cycle as well. All right, so I'm going to move to, I want to give Doug plenty of time to talk. So that is just sort of an introduction to shared models. I've been doing this for a long time in the shared model space. I'm happy to talk to any of you who are interested in more. Doug, I'm going to pass this to you. I want to make sure that everybody has a chance to hear about what is happening in automation and agentic AI as it relates to the credentialing world.
Sure. No, thank you. What I usually like to do is try to explain the differences in some of the models of it. Now, AI is a very broad bucket, and everybody gets very excited about generative AI, and now everybody's talking about agentic AI, and really thinking that these are kind of very disparate systems. But I kind of want to read these for you, and then we'll loop back to it in a second. So deterministic AI, which historically has been called discriminative AI, is a very specific, I have one question, and so it gets one answer. It's kind of a one-to-one. We have an exacting formula into what the output is going to be. Generative AI is very creative. It's very opinionated. And effectively, you can think of it's going to read large amounts of data and formulate opinions. This is why every single output may be slightly different. This raises concerns of things like hallucinations. It's interpretive in its responses, its outputs, and then it can also be very sycophantic. And so we're going to talk about a lot of these kind of controls and the way that auditors, and we see these massive increases in compliance and audit scrutiny, et cetera. And more importantly, not only national laws and things like HIPAA, but you see individual states, EU and then HIPAA in the United States. You see a Colorado AI Act. You see a California what's called AB Act, which gets into discrimination. So if you're thinking about things like credentialing, those things come up into kind of play here. Texas Responsible AI Act. And so all of a sudden, you're having to not only adhere to all these different regulatory pressures, but keep up with them. And then they have Agentic. And so the Agentic is really, people think it's a new model. It's not. It's leveraging generative AI and deterministic or discriminative AI and the ability to take action onto these things. And the reason I bring this up, I spent a little bit of time here, is because we see people over pivoting and just simply say, well, generative is a newer model, therefore it must be the best model, right? And I'm going to do everything over there. And that's certainly not the case, especially the more regulated you're going to get into. You really want to use as much deterministic as humanly possible, and generative where it's really needs to. So you should think about these as an and conversation, not an or conversation, I think would be the primary point here. And then we get into kind of agentic frameworks. One of the examples I really like to give is just a finance department, because everybody can understand it. And you don't have one guy in a finance department that's simply doing everything, right? You have some of that's really responsible for AP and some of these billing and collections and so forth, and financial reporting and so forth and so on. Agentic AI is designed by its very nature to operate very similarly. And so I just kind of took a credentialing process and broke it down to the individual agents and kind of how we would think about these things and leveraging different capabilities within AI models. So obviously the very first part, we would want to ingest documents. So as said earlier by Kimberly about PDFs and fax documents and these type of things. When we're using computer vision, is it not OCR? We don't care what format. Yes, if there's some smudges or things, obviously we care too. But literally, we read documents the exact same way that a human would read those documents. So you can kind of think of it this way, and we can parse out that information. But more importantly, and if you look at some of these changes that especially Ankur was referring to around data cleanliness, and this is really getting into very specific audit trails and a lot of this compliance and new regulatory challenges that are rising, is how accurate underlying is your data, because there's this view that AI is this black box and what's feeding it is this data. So how is this making those decisions? It's making the decisions off the data. So we're going to go back down and we're going to take a look at the data. So as you're ingesting documents, you can really kind of put a lot of controls around a data validation agent that has no other purpose in life other than to live, eat, and breathe, validating and adding to key elements of critical data within, let's say, a credentialing process. And then just a couple more examples. Obviously, you have things like outreach. So if we're using things like conversational AI and we want to understand sentiment and we need to collect more data, we can collect that. And again, as that collection process is going in, we can still run that through the data validation agent. And then usually almost everybody's really interested in things like fraud. And so again, fraud, the only thing it really lives, eats, and breathes is the understanding of what are those kind of key indicators that would indicate that there's a fraudulent attempt kind of going on, and what's that propensity for fraud. But more importantly, agents are not, again, monolithic systems. So you can think about, I need to design a new workflow system. And as you build these individual agents, which are kind of like you're hiring individual roles, then you formulate and you structure the agents around that very specific process. And I know I'm going very fast, but we don't have a tremendous amount of time to go in depth, and I'm happy to answer any questions. But one of the other big questions I get is, how do we get into this compliance and this audits, and how do we kind of get ahead of these things? You often hear, how do we put humans at the center of this, and how do we kind of learn and train based on all the human understandings that we have? And one of the best ways that we get to this, and how do we take from pre-trained into finally to discriminative models, is through something called HITL, human in the loop. And so if you take just a ChatGPT as a good example, that is a pre-trained model. It has no understanding of your compliance obligations, your systems, your nuances within your process flow, anything else. The way that we typically organize these things is we'll use a larger model, a pre-trained model, have it interact and have it recommend answers or suggestions and learn from interacting with these humans. And so this is just a really good example, is sometimes we'll give it, well, here's what I think. Again, it's probabilistic. I think these three these three answers could be the right answer, but I'm not quite sure. That's why it's passing off to the human. The human is going to validate what the right answer is. So let's just say in this very example is they select the second answer as the right answer. In that case, in that one instance, answer A and answer C get a lesser confidence score, and answer 2 or B gets a positive confidence score. So over time, as more and more humans are validating that that's going to go up, then that's going to go to the very top, and they're going to keep validating, and then that's going to become a critical part of the foundational workflow. And so these are the ways that we get into how do we get to pre-trained generative and probabilistic models into very deterministic models that are trained and based upon the nuances of how my business operates and my regulatory and audit compliance requirements, et cetera, et cetera, et cetera. Last thing I'll add is once you kind of put these models in place as well, more importantly, because it's providing these suggested answers or workflows or tasks or anything else to the human, you see not only an immediate improvement into the operational efficiency of that human, and you're learning, the AI is learning from them, but whoever has the best answer, let's just theorize that there's a best answer. Not every single human knows it, but if all of a sudden they say, hey, by the way, most people think that this is the best answer, most humans are going to say, you know what, that answer is a lot better than what my answer is going to be. And so it's a really kind of great way we call neural knowledge of elevating all humans at the exact same time. I apologize if I went a little bit fast. I just want to be a little bit sensitive of time, but thank you. And with that, I'll turn it over to Ankur.
Thank you, Doug. So now I think we talked about the issues that health plans are facing. We talked about the impact. We also talked about how and what forms of AI can help health plans. Now, one of the things which we believe health plans should watch out for as they are innovating in credentialing, uh, you know, I'll touch upon a couple of them, and then I'll ask Doug and Kimberly to also chime in. So when a health plan is thinking about you know credentialing transformation of credentialing, working with an automation solution provider, they have to think about it not as an IT project. It's not something that you can work on your credentialing platform. You have to think about it as a transformation project, which means you have to work across different silos that exist within an organization, right? So you have to think about your provider data management team, you have to think about your contracting team, your network management team, your claims team, and think about how you can transform the process. And yes, as part of the transformation, you have to think about the automation of credentialing and so on. So credentialing automation, it's not a IT project, it's a enterprise transformation project, and that's how you should deal with it. The second important point is the change management, right? I think sometimes clients come to us and they tell us that they have invested so much in technology, but they're not getting the right ROI. The problem doesn't lie in technology. The problem lies in how effectively you have enabled your organization to adapt to the technology change, right? So have you created a change management team? Have you created the right training modules? Have you created the right governance structure? So you have to manage the change deliberately. You have to own the change. You have to take the buy-in from different teams, which I believe is one of the most important part of as you think about the transformation of credentialing. Now, Doug, you talked about AI, right? And when we speak with the paid clients, one of the things that they always highlight is that even if they invest in technology, they believe their data management strategy is not up to the mark. It's not right. So, as you think about data management, what advice would you give to healthcare payers? So, to have the right data management strategy so that they can invest in the AI solutions you talked about.
Yeah, well, I think one of the biggest mistakes that we see is if you look at just the stats, 80 to 90% of AI projects fail. And Ankur just mentioned the second biggest reason. The first biggest reason is the underlying data is not done properly. The second reason is they fail to meet an ROI objective because they don't really have a baseline of what they're trying to achieve. That data element is something I talked about of how do you get to clean and attributed data. One of the biggest things, just so we're not going down a rabbit hole here, is everybody kind of thinks I'm just going to go hire a data scientist. Well, data scientist is understanding that you're already going to have all your data frameworks. And one of the fastest growing jobs in across all sectors right now is data engineering. But when I talk to a lot of CIOs and others, they kind of skip over to the point and just say, I need a data scientist because I want to be able to do AI. If you do not do the underlying data properly, I can promise you that the output of the AI is going to be incorrect. And so one of the biggest things I kind of get to people is, okay, we take a generative AI, when I say it's going to hallucinate, let's just call it lying. It's going to lie to you at some point in time, and it's going to want to please you. And I'm going to give it bad data, and I'm going to give it then access to take actions within my most critical systems. What could possibly go wrong, right? And so you really have to think about these things on the front end of good data. And I'll kind of talk about the compliance aspect, because from where I sit, across many different dimensions of where I operate, compliance requirements are going through the roof right now. And so the more that people think about, this is a human that's going to make a critical decision against my most critical aspects of data and systems. How do I going to audit and ensure that that decision is right? We have done this for decades across humans. There's so many different controls around this. But when an AI is kind of a black box, and we're going to throw it in there, and hopefully we're going to trust it, and hopefully it's going to come out wrong. Well, my biggest point is, think about AI as a human when you're putting in audits and compliance and observability, and then work yourself backwards.
Thank you, Doug. So we're slightly running behind on time. Kimberly, a quick question for you. So I think there has been a lot of conversation in the industry about the compliance, right? But sometimes it becomes difficult to keep compliance in check, with the provider experience as well. So when you think about both of these part of the equation, what recommendation would you give to the payers to, so that they can keep the compliance in balance with the provider experience?
Yeah, and I'll try to be very quick here. I think fundamentally compliance is a KPI that everybody understands because it means risk and liability, and from a business perspective, you're looking at that. I know that provider satisfaction has certainly, in many cases, taken a back seat to member satisfaction and other things. But as you start to look at how you implement these programs, how you implement outreach to the providers, how do you minimize outreach to the providers? How do you pull data that may be accessible in other ways, leveraging the information that either you have or that in a CAQH model or a common application model? How do you make it as easy as possible for that provider office to get credentialed? So that you can make that turn time as fast as possible, and again, seeking to help the more the provider is engaged in initiatives that you're making to try to make that happen, the higher that KPI can be raised. I know that many organizations were starting to say provider KPI as being one of the key KPIs, simply because there's the lack of providers in the industry and the desire to attract more. So,
thank you, Kimberly. And now for key takeaways, let me pass on the baton to Kimberly.
Back to me. So, well, I want to thank everybody for being here. I think just from a key takeaway, what I would say is that if, for the health plans that are struggling with this today, you're not alone. Pretty much everyone we talk to is struggling with some level of compliance and meeting the objectives, the new objectives that are coming in, as well as continuing to streamline operational processes. Everyone is on a continuum. Some are better than others. Some really are struggling. So the compounding of legacy systems and other the new requirements are really creating some challenges. There are paths through. Technology, automation, AI, and shared models can help. I think looking at those and building an ROI with a partner who knows how to do that is always a good thing. Seeking guidance on what is out there that could help you with the specific problems, whether they're upstream problems, downstream problems, lots of faxes coming in, automation of work that you need to do. Partners can help you. I think it's really difficult to continue to have internal IT departments continue to build out and advance some of the technology that is required here, because it's just so monumental. But if you are interested in connecting with us here at Sutherland, we would love to talk with you. So there are plenty of ways to engage with us. You can use the QR code here. You can find us on the web. We're happy to have those conversations. Our job is to work with our clients, and we work with some of the largest clients in healthcare to look at both kind of the full continuum end-to-end process, not just the box of credentialing, but the full end-to-end of inbound through outbound activities that are driving inefficiencies and can improve ROIs and improve the cost structure as well as the efficiency and quality. So thank you very much for joining us today. I want to thank my co-hosts, Ankur Varma and Doug Gilbert. They've I think added quite a bit to this. Really, some interesting things that and perspectives that they bring to the table. So thank you for joining me here today, and we'll open it up for questions.
Thank you. At this time, we're going to address some questions that came in during the presentation. The first question is, as a health plan, how should I think about AI from a risk-benefit standpoint?
So Doug, we'll hand that one to you, maybe?
Oh, sure. Yeah, I think that we kind of try to get people to break it down into a couple singular numbers, if you will. We see a lot of people going for pie in the sky, and they get all the theoreticals and all this. What I really like to do is just do, I mean, it sounds like very simplistic, but just almost time and motion studies and how long does it take a human to do a specific task, and how much can we reduce that task time by using AI. And a perfect example is, again, if I have to read in a PDF document and I have to then go retype all that information or a fax machine, that's a tremendous amount of time, which equals cost. An AI can do that, and they can do 1,000 in a single second, right? And so we can just start to mathematically calculate, I'm taking the cost element out. So that is a cost per transaction. Very simple to be able to get to and be able to baseline. The second number is very simple. It's the value of the transaction, or value per transaction. And this is where you can start thinking about, I have a error ratio of X, and within AI, if we're doing these things, I can reduce that error ratio either in process or downstream, because data cleanliness upstream will cause other error issues downstream. I'm missing information, etc. Also fraud. Fraud is the largest one that we're able to see. Key indicators, we're able to kind of look across many dimensions of data and be able to detect fraud very quickly and very accurately, and be able to highlight and flag those much faster than what a human could do with their kind of heads down and just kind of trying to process the document. So my biggest advice is there's 1,000 different ways to skin this cat. Again, failing to meet the ROI objectives is the number one, typically because they don't have a baseline, number one, and number two is they're trying to shoot for the moon. Putting down those very two simple perspectives, articulate that into whatever executive committee that you need to be able to do, so it's very measurable and achievable, and then you can go off from there. The last kind of point out, not to belabor this point, is yes, doing AI is like hiring somebody, but the beauty of AI is you can constantly continue to refine it. So just put these kind of as measurable steps. We're going to continue to improve our cost model. We're going to continue to improve our value model here, and this is going to be a long-term strategy, not just I'm going to throw it in once and be done.
Thanks, Doug.
The next question that we have for you is, when payers look at automating or modernizing credentialing, what kind of ROI can they expect, and how can they build a strong business case for that investment?
So I'll take that one. And Ankur, I might have you weigh in on this, but so ROI is very dependent upon where you are today and how far you want to automate. So typically what we see is that the clients that we have deployed automation for typically see somewhere between a 30 and 40%, sometimes even greater, decrease in costs for increased valuing, increased quality, etc. Again, it really depends on where you are. What I will say is those that really can understand ROI look at that full end-to-end process. They look at where the data is coming from and understanding the cost of maintaining the data that feeds into the credentialing process, the actual credentialing process, which has often is held, there are parts of it that are sometimes held in different departments. And then the downstream processes. So looking at that end to end, and then figuring out from an automation perspective what you can do. So I can't give you an exact number from an ROI perspective, but I will say that it typically is going to be significant, particularly if you don't have a lot of automation in place today.
Yeah, I'll just add a couple of points to what Kimberly mentioned. I think, as she said, that setting up a baseline is important because that will help you to really measure the improvements that have happened after you have deployed an automation solution. Now, in terms of the ROI, I think there are two answers I can give, right? One, which is the direct tangible benefit. So we have seen in the past, we have worked with some payers. So I think on your investment, you can expect maybe 2x to 4x the returns. So that has something which we have seen after you have put in the automation for credentialing and for provided data management. The indirect answer is that it's not always the cost benefit, or it's not always the ROI in terms of the returns that you should measure. You should also think about ROI in terms of the productivity benefit, the efficiency gains, the number of people that you are deploying on credentialing, and so on, right? So as I said, 2 to 4x of returns are normal in the industry, but you should think about much more than returns when you think about the ROI.
Thank you, Ankur.
Another question that we have is, how can a health plan that is already doing credentialing gain value from a shared model?
So I talked a little bit about this earlier, but if there is a multi-payer credentialing model, a national model, and again, I'm not talking so much about Sutherland here, but we do have one operating in states that you operate, and there's an overlap that can exist between your credentialing and those that are already being credentialed. And I can only kind of speak to this from a national perspective. That overlap is going to drive efficiency and overlap and cost reduction. So that depending on the level of overlap that exists, so we would start with an overlap analysis that would allow us to see what the value would be. Regular credentialing could continue as it does now, but the overlapping providers would be processed through a different process, through that multi-payer model, and sharing that model with the packet configured uniquely for what your credentialing compliance department needs. That's an example of how someone could enter into it. And there are ways of entering into at the cycle. So if it's not mandated and you can join it kind of at the time that's most convenient for you, if there's a provider that's being re-credentialed on cycle and you have that shared provider, from a fundamental perspective, you could receive that credentialing packet, and again, in a shared model environment, participating with those where we know who is overlapping with your network. It's a complex thing, so if it's something that you are interested in understanding a little bit more, I'm happy to talk with you about it. So Lisa, where are we on time? I know we have maybe a time for one more question before we close.
All right, and the last question that we have for you today would be, what is one of the initial items to fail in AI projects in healthcare?
Yeah, I can take that. It's very simple. Again, it's going to, the stats all prove this, right? It's going to come down to data. And I see a lot of people just kind of throwing in AI and never thinking about the data. And especially if you have an outside external advisor and they're not, very first question is starting to really tear through your data and make sure it's organized properly. That's going to be your biggest issue. And within healthcare, then specifically, the second one is different EMR, EHR systems, fire protocols, different data normalizations that we've got to be able to go through. Really, an AI project should look 90% of the time and project and effort is spent on the data, and about 10% is actually putting the AI in place. And if it's anything, you can have slight variations of that, obviously, but if it's inverse of that, I can promise you, you're going to have some issues.
All right, thank you. So I want to thank everybody for joining today. I think we're at the end of our call. We'll follow up with additional data. There's a few more questions that we might follow up with. But thank you for joining us today. We really appreciate it, and we're excited to engage with you if you so choose.
Thank you, guys. Thank you. Bye.
To our speakers, thank you for the great presentation and for sharing your thoughts. Thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you again, and enjoy the rest of your day.